our 7th or something like that. Right, Mike? And we're getting, I think, last week we got like 1,000 views, 1,000 viewers.
Cumulatively, yeah. Usually about like 150, 250 at a time, and then we'll get up to 1,000 by the end of the week.
So there's a lot of people out there watching us, which is great. And then I know we went on to the ASAP EMS listserv last night. Dr. Gore did, so we'll get a few more. If you want to join our email list, we are almost at 11,000 people now around the world who are getting weekly Journal Club articles from us. And you can go to our website, which tells everything about us, www.emsfellowship.com. And then the Facebook live stream is www.facebook.com/EMS Fellowship. Did I get that right?
Yes, you did.
So we sent a few more articles out. Send us your information. I guess you could just post your email on Facebook or just send us an email directly. We added, like I said, we're almost at 11,000 people now who get our weekly lists. Last week's Journal Club got a lot of great feedback. If you weren't with us, we talked about the first article ever, meta-analysis at least, on cardiac arrest patients who have NSTEMIs going right to the cath lab, because we know certainly if you have a cardiac arrest, you get ROSC, and then you have a STEMI on your 12 lead, you belong in the cath lab by pretty much every study published. But now we have a meta-analysis last week in resuscitation, which is Joe Ornato's journal, maybe he's listening, which says that NSTEMI should go right to the cath lab, and you have a clear mortality benefit, and you have a benefit with CBC, cerebral perfusion scores as well. And the best literature, I think, tells us that about 30% of people have culprit lesions who have NSTEMIs and EKGs after they have cardiac arrest and ROSC. So hopefully that 30% will push people into the cath lab, and we can activate cath labs more routinely for people who have NSTEMIs, not just the easy STEMI. And then, of course, we reviewed the CCCPR. A lot of people emailed me and asked me for that article. So we certainly are fans of PICC for CPR. Despite the 2015 nickel paper, which basically said you have to ventilate, PICC for CPR may not be the complete answer. But the CCCPR, the first article came out in children. And although we have about 4 papers on CCCPR being a good thing to do, compression-only CPR for people in the malls or at the swimming pools, etc., in children it seemed that CCCPR was inferior to ventilating as well. So maybe for kids, CCCPR is not the right answer. If you go down in a mall, we should teach people that for children, you should ventilate too and not just do compressions. And that was the only study ever published, and we reviewed it here last week. So we'll review a few more articles. Let's start with interesting pre-hospital or even emergency department cases. If you guys were here, you would know that there's lots and lots of people who are sitting on the outskirts of me, but very few people are willing to get on camera.
Oh, they'll get on camera.
The good thing is we can move the freaking camera so we can see you unless you don't want to be seen. And we're going to stop at 2:30, which is like in an hour and a half. So interesting cases. Anybody? Pre-hospital?
I have one.
Okay.
A African-American female, 60-ish, 62, rectal bleed, frank red blood mixed with, looks like dark blood, probably clots, along with sadly, some feces. I'm guessing about 1,000 milliliters, writhing in agony. Load and go. We're 5 minutes to the hospital. She's complaining of leg pain and won't let us lay her legs flat. And she's, besides rectal pain, she's complaining of this great leg pain. So I was concerned that it might be a aortic bleed of some sort, something going on. We get her in the hospital. Dr. McSweeney can't even examine her.
No names. No
Okay, sorry about that.
We have to edit that out.
The doctor cannot examine her because of this writhing in pain and complaining of leg pain. So he says, how much ketamine do you guys use to knock people down in the field? So we gave him our best guess of 200 of ketamine, followed by maybe another 100 after that. I never found out what was wrong with her.
So just, all right, so for ketamine, the dose really depends on what you're using it for, right? That's the kind of bottom line with ketamine. And we know for agitated patients, we have 3 studies which looked at 4 per kilo, 1 study which looked at 5 per kilo, and then the books will all say for agitation, give 4 to 6 per kilo because you can, great thing is you can make stuff up and everybody will believe you. But the right answer is probably 4 per kilo just because that's what most of the literature shows. And then if you're going to give it for intubation,
That's
where
what
you
he
know
was
we
gonna do.
intubate. You know, I'm a big believer in prior to intubation it's rock and ketamine, after intubation it's fentanyl plus ketamine,
Right.
and then maybe a little fentanyl beforehand too to help with the ICP, although that's terribly weak literature.
I'm guessing she was 160
And if you're going to get
pounds.
fentanyl before, it's really 3 mics per K, not a lower dose, and you have to wait, right, which most people won't do
Right.
anyway. And then if you're going to give it for like pain control, pain's lower than dissociation doses, so it's somewhere about 0.5-ish per kilo, depends upon whose paper you believe, right? So, but ketamine, you know, it's what we do, right? We give 1 dose of fentanyl, right? We stop giving morphine. If you're still giving morphine for STEMIs or pain, you're only a little bit behind the times, right? I don't think it's the worst thing to do in the whole world, but I think fentanyl has some theoretical reasons to be better. And so we give usually 1, 2, 3 doses of fentanyl. If that doesn't work and you have real pain, then I hit you with ketamine right away. You guys do the same thing, right? And and what I was thinking, first I was thinking, where's the dividing line between upper and GI bleeds, upper and lower GI bleeds? What's the dividing point?
The stomach, didn't it?
No?
Ligament
Ligament of Treitz. Ligament of Treitz intersects with what part of the duodenum? The duodenum is like the C loop of the duodenum. It's got like 4 parts. So between what parts does ligament of Treitz intersect with? Yeah, I think it's the second and third. Is that right? Some of you guys who are younger, it's the second and third, right? So anything above the ligament of Treitz is upper GI bleed. Everything below the ligament of Treitz is a lower GI bleed, right? So this is why if it was the old days and you dropped an NG tube in somebody, you didn't get bile back, you didn't know if it was upper or lower, right? Doesn't really help. So yeah, so fentanyl and then ketamine, sure, for pain control.
So she could have used more probably. She was 160 pounds and he wanted to intubate her.
Yeah, you know, I mean, if you need to get somebody under control and they're having severe pain and you need to do like put them on a diagnostic journey, we always say, you know, knock them out, intubate them, and if you're having trouble controlling their pain and they need the CAT scan really, really quick, then I certainly think it's okay in some people to make the decision to take away their airway quickly because you know that the time to get a CAT scan result that you may need to act on is very, very important. Everybody kind of agree with that? Yeah. That's good, straightforward. You know what happened to her?
I wish I did. We tried calling and couldn't get a definitive answer.
Okay. Anybody else? Cases in pre-hospital or in the emergency department? By the way, you know, what's the artery that makes your legs go numb? This is like question 53 on boards, right? There's an artery that goes to your spinal cord that makes your legs go numb when you're dissecting. You dissect down this artery. What's the artery called? Artery of Adamkiewicz, right? Some people say Adamkiewicz. I used to say Adamkiewicz. I mean, from the time I was 10 to 12, I said Adamkiewicz, and then after 12, I started saying Adamkiewicz. So if you want to know, like when you show up and somebody's legs are numb or they can't move them, and you're thinking the aorta they're dissecting, it's the artery of Adamkiewicz that is being dissected, which goes right into the spinal cord off of the aorta, and that's why their legs go numb. Who had an interesting case? Josh, is that you?
I had one, but if you go first.
Yeah, sure. I had one. This was in the ER, working at a satellite ER. You know, so kind of limited resources, but basically she was a 21-year-old female, somewhere around that age, coming in with pretty severe asthma exacerbation, breathing probably 35 to 40 times a minute. She had retractions. She was hypoxic in the high 80s, low 90s. This was after she had been trying home albuterol, about 1 treatment every 30 to 40 minutes at home since night. So she already came in with a heart rate of 130 by the time I saw her. So, pretty quickly she got IM epi, she got MAG, she got solumedrol. It seemed though everything we gave her in progression, she just clinically was getting worse and worse and heading towards intubation. But what we identified was that it seemed to be the factor that was making her get worse was actually her coughing, because she had these coughing fits. And just as soon as she started coughing, she couldn't control herself. She would tighten up very quickly. So what do you think we used?
So are you going to tell me that you read last week's clinical pearl,
Yes.
which talked about nebulized lidocaine for cough, asthma? So for severe cough, lidocaine. So tell me that.
So we were actually, I was getting pretty close to intubating her, setting up and everything. I was thinking about low-dose ketamine, And I was
As a bronchodilator?
As a bronchodilator, maybe we could dissociate her a little, let her calm down. She wasn't tolerating BiPAP either. She was ripping it off. So ultimately gave 200 milligrams of ketamine nebulized, and
So you gave nebulized ketamine.
or no, not ketamine. I'm sorry, lidocaine.
All right. Well, I was
But
getting
we talked about
excited
that before,
because we just reviewed the
and-
case report
Yeah.
of nebulized ketamine, and we liked it, right?
But the nebulized lidocaine actually seemed to do the trick. Once we controlled the coughing, it was easier to talk to her and say, look, you need to focus on your breathing. I would say focus on exhaling more, take big, deep breaths, and focus on breathing out. She also had pneumomediastinum, as we learned from the X-ray, so there was a considerable pain as well, and probably triggering some of her J receptors, causing her to cough more. But she, I ended up giving her a little morphine too for the pain, so I don't know what it was.
Not fentanyl. We'll let it go.
No, we didn't have fentanyl.
But pneumomediastinum, although you do get it, right?
Yeah.
It's not the worst thing in the world. In fact, it's been in vogue for several years that if you're somewhat stable and you're younger,
And
you can go home with a
you just go home,
pneumomediastinum, right?
Yeah.
We don't do anything about it. It goes out spontaneously. Only when you're a little bit older do we slam dunk admit pneumomediastinums, right?
Right. And she was 21, so she was somebody who I would have, if she didn't look so terrible clinically for her asthma exacerbation, she's probably somebody I would have discharged home if we controlled the cough.
And I assume you picked up the pneumomediastinum on chest X-ray.
Yeah.
Right.
Yeah, she had.
Can
pretty
you find it?
classic,
You can probably find a pneumomediastinum on ultrasound, right?
I don't know. I mean,
sure-
I guess you'd see some artifact.
I'm sure the 1,000 people out there right now, somebody's saying, "Of course you can, you idiot." Right. So there's probably some finding for ultrasound, lung ultrasound for pneumomediastinum. I just don't know what it is, but we'll know by next week. So you gave her nebulized lidocaine. She got better.
Yeah, surprisingly.
I mean-
I was telling everybody it must have been the nebulized lidocaine, but they thought it was the pain control, the morphine that we gave. So I don't-
Maybe, right. One of my old mentors said there's two types of asthmatics. There are the ones who present and they've only been sick a couple of hours, and no matter how sick they are, you can usually get them better. And sometimes you intubate them, but then there's people who've been short of breath for 3 days. That's why it's so important to say, how long have you been short of breath for? Because once they've been short of breath for over 24 hours, they're starting to get mucus plugging. And no matter what you do for those people, when they start to decompensate, you're not going to help them without intubating them, right? You still throw everything at them, but you should be aware, if you've been short of breath for more than 24 hours, the risk of mucus plugging goes up dramatically, and when they decompensate, they can get really, really sick really quickly, and nothing you throw at them may work.
Right. And sometimes even the more beta agonists you're giving them, more albuterol they're getting, it loosens up that mucus, and it just seems to exacerbate the problem.
Right.
So sometimes, like you said, after you get them intubated, you start suctioning, and it's just, you fill up the suction container with just mucus.
Right. This, by the way, is why sometimes we'll throw Z-Pak to some of these people. Everybody thinks we give Z-Pak just because it's an antibiotic, and that's not really true. Z-Pak is also a mucolytic, and it's also an anti-inflammatory. So it works by 3 mechanisms, so it's not that Z-Pak's just as an antibacterial.
Didn't we review that article there? They just disproved that with the pediatric population.
Right, so there is some literature that speaks against that, but right. See, the problem is if you have smart fellows, you're screwed. All right, so other interesting cases? Who's next, Josh?
Yeah, I had a case yesterday. Came over for an unconscious. We got to the house and was up a small flight of stairs in a narrow hallway and then into the bathroom. The guy was going, I guess, trying to go to the bathroom and then ended up just becoming completely unresponsive while sitting on the toilet. He lived in I guess some sort of group home, but he was like 90 years old almost. The staff there said that he does this typically, and they would normally wait a couple of minutes and kind of see what happens, but this period of unconsciousness lasted for longer than the 2 to 3 minutes that's normal for him when he's going to the bathroom, so they called us. When I got there, we got a finger stick, which was normal, and took his blood pressure, and it was like 60/40 or so. So I mean, it's not, the case wasn't very complicated medically, and I think he probably was related to having a bowel movement. But I think the reason why I kind of want to talk about this is I want to hear about your guys' management of like when you have someone in these very tight spaces. This guy was in a tiny bathroom, sitting on the toilet, and to get him out is a very small hallway as well, and we would have had to bring him downstairs. So I ended up just doing everything while he was sitting on the toilet. Got the blood pressure there, started a line, gave him fluids, his pressure came up, and then like when we laid him down, I don't know if it's from the fluids that he got or from laying him down, he actually started waking up and getting a little bit better, and his blood pressure went up to the 80s. So I don't know when the right time, and I don't know if the right time is to take this guy off the toilet right off the bat, carry him down the stairs. It's going to take 5-6 minutes probably until someone goes outside. So all I had was a stair chair there, so I'm not going to take the guy off the toilet, put him on the stair chair just to carry him down. Or you go get the Reeves. Someone's got to go out to the ambulance, get the Reeves, get him on there, but he's not really getting any care in that interim. I mean, he did get better by the time we got into the ambulance, so I think it was fine what we did, but it could have been done better if if we had laid him down first. I don't know.
Was he responsive when you guys got there?
He was completely unresponsive. Yeah.
But you didn't believe it was a volume issue, correct?
It could have been I didn't
was
really
there
know
blood
at
in
the
the
time.
toilet or anything else?
So his pants were still on at the time, so he hadn't quite made it to the bathroom. But the staff said that this happens to him routinely when he goes to the bathroom. Then later on, we heard that there was also some black stools, possibly, but.
Well, I guess initially you thought it was just a simple vasovagal, right? Maybe not
it could be a simple.
one,
It could be a vasovagal, but generally, if the guy was there for 10 minutes, he probably should be coming back. By the time they call EMS, like vasovagals usually self-correct.
I mean, he could have been in cardiac arrest for all you know.
Right.
I mean, there's no right answer. If he was in cardiac arrest, how effective would have been your CPR, your ability to intubate, your ability to put pads on, your ability
Right.
to
So I think
shock?
if he's in cardiac arrest, just take him out. Get him somewhere.
That you
'cause
can
he
get
can't do
into.
anything there.
Did you do a VGL on him?
Yeah, it was 130, 135.
So
Right.
you ended up popping a line in? And then
Yeah, so we popped the line and gave him fluids and kind of got better. I mean, I think it was probably related to his pressure because his mental status really got a lot better once his pressure started coming up.
But what would you guys do? I mean, I'm sure you find people next to toilet bowls in cramped environments all the time. Do you grab the guy and bring him down the steps where there's more room to work on him, or do you at least do a couple of things right there, even though you might be the only provider who can get into a small cramped area?
So I would think that if we could just literally pull him out to the hallway, a couple feet, and 15, 20, 30 seconds, we would do that. Otherwise, I think we would all in this room, I think we'd all pop a line and give him some fluid, try to at least stabilize him. That's what we do, and then make a decision. on how
In the
we get him.
bathroom,
Yeah.
even if you're the only person who could get in there.
Yeah.
Certainly before moving him downstairs.
Sure.
I mean,
So if he was in a really confined area where you couldn't even get in there except for maybe half of your body and had to reach in, then maybe you'd pull him out a couple of
Right.
just to,
if there's no physical space to work within, you have to move him to where you have physical space. But I mean, our goal is always to initiate care as soon as possible. I'm not a big fan of delaying care for 5 to 10 minutes while I move somebody downstairs. If I can just get him out to a space where I can get on one side of him and start working, then that's almost always what I'm going to do, unless it's a dynamic situation where I really can't work in that environment.
right.
And sometimes it's very complicated to get a patient out, especially like a big diabetic. And we sit between a washing machine and a dryer, and we do what we got to do.
Yeah, I mean,
Right.
people tend to code between the tub and the toilet. I mean, that's what we're used to.
I mean, what do you think?
Yeah, I mean, I think probably either way is reasonable. I think if there's no room to work, I mean, in this guy, I think that what was going on with him was related to his blood pressure. So him staying on the toilet is not optimal to get his blood pressure up. What I really want to do is get this guy lying down. But if I lay this guy down on the floor in the bathroom, then I can't work,
Right.
basically. And
Well-
if I took him out to the hallway, I can't work there either. I got to take him down the stairs there, and that just created. So I think doing it there was probably, I mean, it's not ideal, but I think for this situation, it's probably.
Listen, at least you didn't do anything silly like orthostatics. Right?
Sorry,
Stop doing
stand up, please.
orthostatics. We
Sorry.
wrote the
Yeah.
paper, lack of utility of orthostatic vital signs. Stop doing it. Everybody listening, stop doing it.
So Dax Spencer commented and just said he hit the nail on the head. There's not really a right answer. I think it's very dependent on the situation the patient is in.
Because we're reading people's comments
right,
because
as
we're on
going.
Facebook
These are all
live
in real
stream.
time. Yeah,
Right,
so, I think that's it. It's a case by case situation. That being said, I think the layperson's mind of what we do when we show up to a scene when somebody's unresponsive is like the Pulp Fiction. You show up to them and you stab adrenaline into their heart, and then they wake up and you should be able to get them out. So
Little do they know adrenaline does nothing. So,
Right. So, or you stab it into the side of their neck, and then that gets them up and going. So I've been on a few scenes where we're trying to treat somebody in an enclosed space, and the family members are saying, "Why aren't you doing anything? Why isn't he out in the ambulance yet, or anything like that?" And you just try to explain, we're trying to stabilize before we transport down and out the hallway. It's going to take 10 minutes to get out. So I think it's a situation by situation basis.
Right. Okay, good. Anything else? How'd the guy do?
He did well. It was actually the staff there was so happy. They thought we like saved his life, and they were like so impressed. So that was nice. And by the time we got him to ambulance, he had his normal baseline mental status back, which was Alzheimer's. But he was good. He was better. So I think that's what's important. It was nice. I had a rotating resident with me yesterday on that call. So in the ER, you get when someone comes in and the medics say this guy was like completely unresponsive, blood pressure is 60, and then you deliver him to the ER, and the guy looks like $1 million. As a physician, sometimes the nurses are like, well, that can't be the case. And I think it was good, for her to see as well that, this is what we deal with in the field, and what gets presented to the ER could
Right.
be completely different than what it looked like in the field.
People always ask me, should we take pictures of cars and bring them to like the trauma bay, or they hand you the pictures if it's a good thing. Well, if the doctor saw more pictures of the cars, they would order more CAT scans, because it's very easy to say nothing's wrong with you when you don't see the other bodies and all the other cars. And I believe I just believe intuitively we would CAT scan more people if we saw pictures of more motor vehicle collisions, because we would say, oh my goodness, I know the guy looks great, but look how bad the scene looks. I don't know, we poo-pooed a lot of mechanism of injury literature, pre-hospital. We were poo-pooed in the Nexus trial for determining who needs x-rays for C-spines or now CAT scans. So we've basically said that mechanism of injury doesn't mean that much in the science anymore for determining who needs imaging tests. So I don't know that we do anything different, because trauma is very cookbook medicine. Either you know what to do or you don't. So I don't know whether showing us images for the average motor vehicle collision just doesn't make any difference with what we do for patients, right? Just like carrying a thing on your vest that says that you're, O positive, doesn't mean anything. We're still going to check, right? You don't need to do that, right? Anything else? Other interesting cases? No? Okay.
So there was a comment I had from one of our EMS attendings. They took a pediatric call. It was a cardiac arrest, and they defibrillated the patient multiple times, gave him arrhythmics. And they were on scene probably for about 25 to 30 minutes, I think. And they got Ross, and they transferred to the closest facility. I think one of the family members was an ER doc, and they were a little upset why the patient wasn't transported sooner. And I think, on talking with the attending, he said that the care was amazing, everything was done properly, he thinks that the care probably would have been done better than what you probably would have gotten when you get a kid coming into an ED, it's just, it's a little hectic, right? So they were able to do it in a more controlled environment, in at least pre-hospital setting, what we feel is controlled for us, but, and he said, he gave feedback to the medics that, he probably would have moved the patient sooner, because, most kids we try to load and go and kind of, do everything in route. And it brought me back to, I think, one of the articles that we kind of looked at maybe 2 years ago. I don't know if you remember this one, but we looked at cardiac arrest and outcomes and what time do we really transport patients. And I'm going to be looking for the article because I just spoke to him the other day about it, but I felt like what we looked at was sometimes there's an average range of where there is a true benefit for patients to stay, and there's an actual age range too. So it's like your neonates, your infants, and then you have your children, and you have your adolescents. And we see that children who are a little younger in age, sometimes they benefit from an initial resuscitation. And I think the average time was anywhere between 15 to 20 minutes is the average length of stay that actually showed true benefit in actually working resuscitation before transporting, versus some of these other kids where we're actually just loading and going. And I think a lot of it is because most of these kids have an airway issue that's probably we need to deal with, and the time it's taking you to actually kind of load and going into the back and then try to do some intervention versus actually doing it there in the field may be the true kind of changer in the game. But I don't know what your thoughts were on this. I don't know, Bob, if you actually heard about this case or not.
Mm-hmm. You know,
Yeah. That's the one you call. I think it's the one you text me
yeah,
on.
so, I mean, listen, we know generally that trauma is load and go, and then medical patients, you do better by staying on the scene for
Right.
people in cardiac arrest. And we know this in all comers because you're better perfusion, and once you make a decision to move people, your end-tidal CO2 starts to go down, you don't perfuse well, your left ventricle isn't squeezing as well, if it's squeezing at all in cardiac arrest, right? So we do know staying with these people rather than moving them and doing bad CPR, when you're moving people, even with a mechanical device, is not the right thing to do. Are children any different? Well, I don't know of any study which compared mechanical versus manual CPR in pediatrics only. In fact, I can tell you that no such study exists to my knowledge. But I still think it's the same thing. You know, if a kid is in VF, which is rather uncommon, we only have one major trial of kids in VF as far as what to do in the United States. And most of these kids, by the way, are cardiac kids. Rarely do they get seen in the pediatric emergency department, and then frequently they get seen in the hospital. I still think it's probably reasonable. Now, again, last week's trial on CCCPR in children shook us all up a little bit, which said that CCCPR is probably the wrong thing to do in pediatrics. Probably interrupted compressions is probably the right thing to do. But I still think for kids, if you're in VFib, which is unlikely, getting that ROS, getting a rhythm, and doing good compressions for that kid is probably the right thing to do. Because now I'm starting to think that maybe that kid has HOCM or something along those lines. So I think to stay till you can get ROS is probably a reasonable idea. Like anybody else, you give me an airway issue, I'm going to the hospital. You give me some reason to believe this is primary respiratory, and maybe the kid, you know, as EMS physician, maybe the kid benefits from like VV ECMO or something. Maybe those people I'd be pushing to move a little bit quicker, but if you give me the same VFib arrest, although the cause may be different in a kid, I'm still probably going to stay till I can get ROS and get intubated, unless I'm running into any problem, right? Which certainly could happen in the house. Maybe you can't do effective stuff in the house because the child and because the family won't let you. But that's usually not the case. You know, I mean, there's a little more to the case, which we're not going to discuss, but Bob, what do you think?
I thought they were really aggressive. I mean, I don't know that the ER would have been that aggressive.
Yeah, we read the chart, right? We agree. The medics did a really good job on this case. I mean, this was a real cardiac arrest in a kid who was how old?
3.
In a 3-year-old. So it was a real cardiac arrest. There was real VF and a couple of things on monitor, and they got between getting the airway immediately, between handling all the arrhythmias immediately, between putting the IO in immediately, between controlling the scene. You can't ask for much better than that. They did like a fantastic job, and I'm not sure there's much I would do to critique them.
Yeah, I mean, we basically teach now, stay there until you get, Roscoe pronouncement. And, they effectively treated that child.
Right.
Right.
I feel like I wouldn't have opted to transport this patient immediately. I would have said do exactly what they did, and probably. I mean, I stand by their decision to stay and actually.
Unless you give me a reason, like you have to just give me a reason
right.
of what the benefit would have been to move to transport quicker and an uncontrolled scene. The truth is, and we all know this here, that pre-hospital leads the way for the emergency department. I mean, we give everybody push dose nitro, we give everybody push dose epi, we give TXA. We do all these really cool things, and we give lots of ketamine, and the ERs lag behind us. And the ERs follow us. So the truth is that kid probably did get better treatment by people who are probably calmer, right? Because the patient was 3, right? Again, listen, you give me 2 people who say I don't have that much experience taking care of 3-year-olds in cardiac arrest and things aren't going well on the scene, and I'm willing to acknowledge that, then start moving to the hospital. But now you have somebody who's probably going to get inadequate CPR because none of us do good CPR in the back of a moving ambulance.
Right.
So someone asked, do you think having an EMS physician on the scene affects how much we're doing on the scene?
Right. Well,
I think it does.
Listen, I mean, if you follow the literature, and we have several EMS physicians in this room right now. I mean, there's about 7 papers which all show better outcomes to have an EMS physician on the scene. Clear, better papers, pretty reasonable statistics. Do I think you need it? No, I would say 99% of cases you don't need it. Just like 99.5% of the time, when I speak to a medic unit, there is no benefit me speaking to the paramedic unit. However, I do think that 0.5% of the time, I have something clear to offer, and for a good EMS physician. And sometimes that is a multi-drug overdose. Sometimes that's because I know what's going to happen in the hospital when the patient gets there. Sometimes it's because I know like that hospital that you're going to may not be able to deal with this. So sometimes it's those things, but there is clear benefit if you put the right person. And there's people who are very pro EMS, and all of us around the table. I mean, most of you guys were EMS physicians here, were paramedics before you before you went to medical school. There is like a clear benefit, but you don't need it 99% of the time. The other thing is we have extra good drugs. Whether that would have been helpful in this 3-year-old in cardiac arrest, the answer is no. Right?
I mean, the clear benefit sometimes, I think, especially when you're talking about cardiac arrest in general, would be being able to have coronary care ultrasound actually available to you that we have.
That's a good point. So we have 3 pre-hospital ultrasound machines now.
And that's the missing link, really, from what we're going to do extra in the emergency department versus really pre-hospital. Is looking for that infusion, looking for cardiac wall motion abnormality, looking for that wall motion or even low EF state in a PEA, and that's kind of where looking for lung sliding in the case of a pneumothorax. So that kind of is what we bring to the table in a cardiac arrest. That's the missing kind of link from the ED to the
right. Plus some extra drugs like somebody asked me this last week, about pre-hospital Keppra, because we carry Keppra, right? Because Keppra is a much better drug than Dilantin pre-hospital because it's much more temperature stable than Dilantin is, which is too temperature unstable. Though I used to carry, I don't anymore. There are studies on pre-hospital Keppra in other countries. The problem is, we have ketamine now. So if your benzo refractory seizure is not responding to more benzos, we give ketamine. We all give ketamine, and we do it over the console all the time, right? And it doesn't happen, but ketamine, my guess is in 10 plus years, ketamine may even be our first line agent for seizures, because you have enough literature out there just for secondary or status epi with ketamine. We know that ketamine works by multiple mechanisms as opposed to benzos, which really just work by one mechanism to stop seizures. So that may be our future.
I think also depending on the system you're working in, you may have more seamless care if there is a physician on scene. There's no need to contact medical control. Everything is done in real time as opposed to having to get on the phone, wait for someone to pick up, ask for an order, and then wait until all that's done to be able to actually give the medication that you need to give.
But we do. I mean, you're one of the rare EMS physicians who is a paramedic first in the inner city. I mean, we all agree that having an ER physicians on the scene is probably more of a disaster than would be any benefit whatsoever. And this was Adam Ray's study, right? The average ER physician only gets 6 days of pre-hospital training during their entire 3 to 4 year residency. So it's no wonder that ER physicians know absolutely nothing of pre-hospital care. But if they knew too much, then I'd be put out of business, right? So I don't necessarily want them to know too much, right? So just like paramedics don't necessarily want ER physicians on the scene, neither do we, right? We don't want them on the scene because they just don't know, right? And and people I think who know us know that we don't go there and take over scenes, right? We're part of the team, and but you're right. I agree that besides some better drugs, and more finger, and we only do finger thoracostomies, that's where the benefit is. Right?
I think a bigger issue is a non-emergency medicine physician on the scene. Those happen actually pretty often.
Fairly common.
Whether it's a pediatrician or it's even a cardiologist's office who's telling us, don't give amio to this patient, or the patient doesn't need an IV, we just need to babysit them at a hospital because they don't understand what we do. I would take any emergency medicine physician at any time because I think they know what they're doing. Of course, the pre-hospital guys or paramedics before, that's fine.
Right.
But as I said, the physicians who come in there, they're looking long term, they look short term, try to stabilize and get to ER. They're 10 steps ahead of us thinking about things and they don't recognize what we can do. One of the first things we do, and I think you mentioned it earlier, is you come into a house and they say, go to the hospital. And we tell them that we're actually the hospital.
Right.
We're the emergency room. So we're doing everything that they can do over there, except possibly for the ultrasound. So on the cardiac arrest, especially. Right, so for that, right, true. But as far as pediatric cardiac arrest, first of all, the Lucas and all those machines don't work for pediatrics. The challenge we have, though, is, and I know we deal with this a lot in our town, lots of pediatric cardiac arrest that we've dealt with, is that what do? If you have to pronounce somebody who's 85 years old, that's one thing. But when you've exhausted everything, and now you're going to pronounce a child in a home, that's one of the biggest challenges. And I think that's why people start leaning towards doing that transport. So we did 3 or 4 rounds, maybe you were shocked, gave amio, whatever it might be, now I think in the back of our minds we're saying we can't do this in the house. We got the mom there, we have other kids, family members, and just even the long-term trauma that they might be dealing with. So we said, you know what? Let's start working on transport. So if it's a 3-year-old, we'll figure out a little backboard, we'll do compressions. It might not be perfect, but we'll get that kid to the hospital. I think that's what goes on in the back of our minds.
Right. And you have the biggest percentage of pediatric 911 calls of anybody in the state, right? 50% of your calls, right, are pediatrics. It's like that's unheard of in the EMS world, right?
We have a lot of kids.
Will you leave a pediatric cardiac arrest on the scene? Is that okay?
Post?
So you pronounce it? Will you leave it on the scene?
Well, in our community, like that's picked up pretty quickly, but we'll do our best not to pronounce on scene.
So meaning you'll always transport it. So is it okay? So if somebody did that today, if they ran a pediatric cardiac arrest and they left it on the scene, would we be okay with that?
Clinically, we would be okay with it. I don't know that it's always the right thing to do.
Yeah, I mean, I agree with what Sim is saying. There's so many other issues you're dealing with, the family issues and like that it's really hard to pronounce a child. I think it's easier to go in and say, yeah, there's nothing we can do. The child's cold, rigor, like that. Once you start working, it's really hard to say, I'm going to.
So of course, you're also saying if you get there and it's death and the baby's got cold or rigor, you're leaving it.
Yeah.
But once we started working it,
Yeah, I think
Just
it's
start
probably
we'll do
more.
our best not to. I don't recall any instance where we work and we actually pronounce.
I think that's pretty universal too. I think it's probably a lot more reasonable to, when you're talking about something where emotions are going to be extra high when you're dealing with a pediatric cardiac arrest, and emotions for everybody are going to be a lot higher. It makes it a little more justified to work that patient for as long as you can on scene to the point where you either got ROSC or you're sure you're not going to get ROSC. And if you're sure you're not going to get ROSC, instead of pronouncing and leaving the patient there, maybe it's best to move with that patient.
I think it's
let the
even a
pronouncement
crew
be known.
safety issue because there is hysteria on scene.
Absolutely,
during
emotions
peace
are
time, so,
sky high, and so I think it's a tough choice because, as we've already said, the second you start moving the patient, you stop doing effective CPR. But is it reasonable to work that patient until you think it's futile, and instead of making the pronouncement and leave that patient there, now move the patient to the hospital?
Right.
So-
And of course, we said that we looked at a study about a year or two ago, which said who are the people going to get ROSC? And I mean, first of all, the biggest study ever looked at this, and about a year ago, and said what % of people who you don't get ROSC on pre-hospitally will still walk out of the hospital alive? And the biggest study ever will shock you. It was 9%. 9% of people who don't get ROSC pre-hospital will still walk out of the hospital alive. Oftentimes, though, with some major disabilities, but still 9%. It's a big number. And how do you identify those 9%? It's all the things you can guess is what they found. A witness cardiac arrest, the first rhythm is VF, a bystander CPR, and tidal CO2 greater than 10 after 20 minutes of resuscitation. So if any of those four, you can consider after 30 to 45 minutes of resuscitation, move to the hospital. The problem we always have consistently is when people do this pre-hospitally, then their end tidal CO2 starts to go down the minute they transport the patient, right? And then what do? And then they get to the hospital. What does the hospital say? There's no chance of survival here. Then maybe some places say, I'll start VA ECMO on that person, right? Especially if they have persistent VF. And we're getting some benefit. France and Germany published their pre-hospital VA ECMO studies, and they didn't have that good findings.
Well, once we complete ours, we'll have different findings.
Right.
So Karen Doherty says the police often ask them to take the child out of the house and to the hospital for that reason, for safety issues.
That's true.
And Jose just asked, I guess this is a just general question pertaining, how long should you have ROSC before comfortably transporting the patient?
That's confusing too, because
I think it's very case dependent again, because that being said, once you have ROSC, even as an emergency physician, what more can we do in the field?
right.
Then we don't have a cath lab yet, and we don't have
Because there's some evidence that not moving these people quickly may have better outcomes and they have this period right after they get ROSC in going back into cardiac arrest. And there's some literature suggested that the best thing we could do is not move them for a period of time. But the best science is we don't know what that period of time is. And if you have a greater chance, and here's how we think about it. Once you go back into cardiac arrest, which you have a great chance of if you got ROSC, right, then you're going to be stuck at the scene again, right? So maybe it's a window of opportunity for us pre-hospitally to move the patient Because again, we know that none of us do that good of CPR manually when in the back of a moving ambulance. So while perhaps there is some benefit in not moving some people, I think there's also a risk in waiting too long with that patient after you get lost. So to me, it still makes more sense to move that patient rather quickly, right? Again, I don't want them recoding. And again, I just know that if they're going to code somewhere, I'd rather be in a hospital where I don't have to keep moving the patient. That's my philosophy.
I think especially with pediatrics, it's a lot about managing expectations and and perceptions, because I think that people may feel that maybe their child didn't get the best of care just because it's been pre-hospital, and they associate the ER with a higher level of care, whether or not it's true. And at the end of the day, if someone's child is deceased, I don't want them going to bed at night thinking, well, they didn't do everything for my child.
Not closure.
And if it's that, of taking the person to the ER and they get pronounced and they feel that that whole ER, the institution of the ER, pronounced them and everything was done that could have been done and they can sleep better at night, that's enough of a reason, I think, to transport a
Yeah,
patient.
because the hospital does. Most hospitals do have a lot more resources than we do in the back of an ambulance, right? So that's what the family needs. They need people they can talk to.
Need to see it, exactly. And I also think, and on the flip side, I mean, the nice thing about pre-hospital care is that we have the luxury of taking care of a patient for as long as we want, undivided. And whereas in the ER, especially in a busy ER, you have people coming in, you have EKGs being put in your face to sign, you have to think about other things, you have to manage the whole flow of the ER, and there's a lot of other stuff going on. And maybe these people are getting a lot better care in the field because then they have to concentrate just on that patient, I don't have to think about anything else.
Well, that's there's that standard delay that we have when we go into an ER, whether it's a seizure patient or even if you're working a cardiac arrest. We always make sure to push that last dose of epi as they're walking through the door, because we know that a nurse can't walk into that room and start, saying, okay, you guys you gave your epi 3 minutes ago, so we'll give the next one in 2. You have to wait for the doc to come in, and everybody's trying to get another one because the 2 lines that we have for some reason are insufficient. They don't want to call an X-ray. They want an X-ray on the patient's tube.
We'll be editing that comment out.
Of 45. Before you know it, we'll look and say, why don't we just stay and play? We should have stayed in the emergency room and done that. Same thing with like an anaphylaxis. When you get an anaphylaxis line of sight, if you're 1 block from the hospital, we're going to treat that patient right there in the back of that bus.
Well, it's easier when the patient's sicker because then you can just use the code card. But I do agree, like if you take like an asthmatic or a COPD, that's another great reason to get this Solumental pre-hospital, because by the time they get registered and it gets taken out of Pyxis, it can really be like 1 hour later.
But Lavin's just saying that maybe it's because there's like an educational gap. There's just a disconnect between what everybody thinks we should do and what they actually think they're getting out in the field. So police think they'll know what we're capable of doing.
Right. So this is why it's so important for us to take people who ride along with us, right? To say this is what it's really like pre-hospitally. This is what my experience is really like. And on the flip side, the big injustice we do to paramedics is we don't let them work in emergency departments, right? Because if people worked in emergency departments, they would get to see that we rarely take traumas to the operating room. We take them all to IR, right? We do all these things, and we make decisions of who to admit for chest pain based upon, TIMI scores, heart scores, social backgrounds, and what kind of follow-up they're going to get, when they're going to get their stress test, when they're going to get their cardiac CT, like a million different reasons. So we don't look at it. We don't look at other people's experience. We just look at our own and make decisions based upon that. Right?
I've had some interesting cases where there were some medics who wanted to pronounce pediatric cardiac arrest in the house, and I've kind of asked, we should probably transport it. Do you think the family's okay with the deceased body being there? And I've even at one point I talked about like even doing TREs in the back of the rig, on the way there, and actually one time one of the medics said I'd rather just continue CPR and let them pronounce once we get to the facility. And so it's sometimes challenging for the medic themselves from their perspective just to not do anything in transport.
Yeah. I mean, from my standpoint, whatever the medic wants is fine with me. Although, listen, if you're asystole, I think a TRE is totally acceptable.
Right.
I mean, we've been doing TREs since 2006, right? But the truth is, many people around the world are doing TREs all the time. This was like not new. Despite this, we get calls all the time about what you guys do. I've never heard of a TRE. But TREs are well-documented literature being done around the world. It stands for termination of resuscitation efforts. There's basically no chance of survival. You're back in the back of a moving ambulance, and we pronounce you. And we don't work on people who have 0 chance of survival. It just makes no sense, right? In our 2-tiered system, we require medics to stay with TREs Although there are many people around the world who do not, and people will just leave, right? But in especially in non-two-tiered systems. All right, let's go to the articles. So we're gonna do the TXA delay article first out of London. A lot of people sent me this article. This was great. So we are now over 100 papers supporting TXA in the acute setting, and multiple we did the pre-doc the study, which is another big pre-hospital TXA article. I mean, if you're not giving TXA pre-hospital or in acute care setting, you're only about 10 years behind the times. And the military, this is their 17th year of giving TXA, the people who see most of the trauma giving TXA. We know it's great in adults, we know it's great in children, we know it's great for nosebleeds. We have a positive literature for some things, but our article on TXA is coming out in January in GEMS. So, Mike, you want to do the TXA delay article?
Yeah, sure. And I just have to add, my wife, who's an emergency vet, gives it to animals when they come in. And
so it's good enough for the freaking animals, but we can't keep giving it to the people.
So they don't always have TXA available at their hospital. They always have caproic acid or some kind of antifibrotic, and they are even using.
Give her a vial from the truck.
What's that?
Give her a vial from the truck.
Yeah. So this, I thought this was just another praise to the drug, and especially to its pre-hospital use. And as we've said before multiple times in Journal Club, TXA is a pre-hospital drug, meaning it has to be given as soon as possible for it to really have any effect at all on patient outcomes. So this was a meta-analysis that looked at, they scoured through a lot of randomized controlled trials, observational trials, and basically ultimately narrowed it down to two. And they were looking at patient-oriented outcomes. So their primary outcomes that they were looking at these two major studies that they analyzed were treatment benefits in terms of absence of death from bleeding. You think about that kind of two negatives, but absence from death from bleeding, and also death due to bleeding was their primary outcome. But also how the treatment effect of TXA, like how long before TXA doesn't have a effect on outcomes. And as we know from the CRASH 2 trial, that seems to be somewhere around 3 hours. Some will say up to 90 minutes, but up to 3 hours, you really don't want to be giving TXA because there's really not going to be any outcome. So that being said, they looked at the patient pools. They narrowed it down. If you look at figure 1, if you're following along. So in the video, we don't put the whole article, but we are able to put the title and the author, so it's easier for people to find this article. I believe this one might be open access because I found this one on Medscape, I think. So,
right. Yeah, I'm pretty sure you're right. This is open access.
Yeah, so you should be able to find this. But if you're following along, figure 1 shows their study selection, how they narrowed it down to 2 trials, and they got huge 20,000 patients from CRASH 2 that they included, and then the women trial that came out recently, I think we actually looked at that, and they looked at postpartum hemorrhage, and they had another 20,000 patients that they contributed to the population.
Postpartum hemorrhage, the women's told 20,000 freaking patients. How much more data do we need, right?
Right, so they narrowed it down to 2, their inclusion criteria. They got it down to these 2 major trials to include into their meta-analysis. Table 1 shows the baseline characteristics, really not too dissimilar in terms of time to treatment. There were some barriers, so they basically considered the time of insult to time to treatment. That's a time that they had to measure to standardize between both groups. So for CRASH 2, it was primarily traumatic injury, but major bleeding due to trauma. These patients got it. So from the time the call was dispatched to the time that the patient was, or they arrived on scene, up until the patient got TXA was that window. For women, the women trial, it was the time that basically the patient delivered up until the time they got TXA. So there's a little bit of a gray area to kind of identify when these patients actually really identify that these patients need the TXA. So you can look at the baseline characteristics. They didn't report the statistical significance or differences between them, but they're actually pretty close across the board. Systolic pressures were a little bit lower in the women trial. I guess that's to be expected. when you start looking at their primary outcomes, so in Table 2, deaths and vascular occlusive events by treatment allocation, they looked at any cause of death as main outcome. TXA, people who got TXA in the crash trial is 14.5%, and then the placebo was 16%, so significantly less. As I think we've talked about crash here. If not, it's pretty readily available. You should take a look at it. The women trial, not as statistically significant in any cause of death. They had 2.3% mortality in TXA group and 2.6 in placebo. So while it didn't reach significance, death due to bleeding did, just below that. So when they totaled all of the crash 2 patients, though, and the women's trial, and if you look at them as a total, 8.4% in the TXA versus the placebo was 9.3%, which reached clinical significance. And I just have to say, pulmonary embolism and DVT, there really was essentially no difference between pulmonary embolism rate of PE and rate of DVT.
So one more time, 40,000 bleeding patients, no increased risk of DVT PE. Let me say that 10 more times, because there are a few studies which talk about increased risk of DVT and PE. This is silliness. This is looking at conclusions of papers, which makes you a dangerous person. So everybody who says, well, the MATTERS trial showed increased risk of DVTs, Mike, what do you say to that?
So MATTERS was really the one that everybody quotes. And if you look at it, it's observational, retrospective, and the group that got TXA, ultimately they were a lot sicker. So their injury severity scores were significantly higher than the group that did not get TXA.
So ISS is what we use in trauma patients, right? I think it's like a 75-point scale. And they had higher injury severity scores. So who's at greater risk of getting DVTs and PEs? Sicker trauma patients. But when you compare apples to oranges, it's hard to make conclusions that are meaningful.
Right. And do you want a DVT or do you want to die? I mean,
Right.
That's the way I think.
Right, but you take a trauma patient who's sedentary and hypercoagulable state, and they're at increased risk of getting DVTs, but not if they get this antifibrinolytic drug. So it's an antifibrinolytic drug. It's not a prothrombotic. So if you look at the major trials, which is the one Cabbage article we looked at, which I think had 40,000 patients. No, I forget. It had like tens of thousands of patients. They had no increased risk of DVTs or PEs. Right, this study, 40,000 patients, no increased risk, or actually just a woman in crash 2 trial, they had no increased risk of DVTs and PEs, right? So, and I tell you what, and if one study comes out tomorrow with 100 patients and shows an increased risk, I'm still going to give this drug, right? Just like the military is for 17 years now. All right, so keep going. What are the conclusions?
Yeah, so the next, really the things that they looked at and the things that I think are more meaningful to us as pre-hospital providers. So you just have to know when your patients are dying. The women's trial was really easy to look at all that data and see that after 2 to 3 hours, that's when most of these patients were dying. So that's still within the window to give TXA. So the group that did not get TXA, the majority of them died after 2 to 3 hours, unfortunately. So they took all of that timing data and they kind of analyzed. In Figure 3, it shows the effect of treatment delay on treatment benefit. I think this is key. So basically, they calculated the odds ratio of survival after getting TXA, and they plotted it against time. So you can actually see their odds ratio, that red line in Figure 3, go down. It starts up near like 1.7 or 1.8, which is significantly reduced mortality. And that odds ratio of increased survival goes down very slowly until about 180 minutes, which is pretty consistent with the crash 2 studies to show there's really no survivability. In fact, beyond 180 minutes, obviously you have a higher chance of dying even if you get TXA. So odds ratio actually becomes negative and goes below 1. Let's see. So
which people always say, well, I don't understand. I mean, this is what, and Dr. Holcomb's a brilliant guy, but this is what he says. I don't understand how the drug can be so beneficial early on and harm people later on. And, right, so I don't know the literature answers that question, but maybe it's just that the patients are more sedentary, more bed, maybe they're more hypercoagulable. I don't know the answer to that, but I'm not going to not give the drug early on because of that fact.
And then they went on and they just basically determined the percent effectiveness based on the timing. And basically, you still have 15 minutes after the insult, so after birth or after major trauma when the hemorrhaging started, within 15 minutes you still have 90% effectiveness. Beyond that, it starts to drop down. But let's say at 30 minutes out, you're at 75% effectiveness. At 90 minutes out, you're at 50 minutes effective, 50% effectiveness. So it's still effective, and it's still going to have a benefit when given within 3 hours. And that's, I think, where it comes to us as pre-hospital providers to say, all right, we have this drug, we know it works now based on this data, we know it works when given as soon as possible, 90% effective within 15 minutes. Why aren't we giving it to all patients with major hemorrhage? We're still waiting on the GI bleed study to come out, but I think it'll be favorable. We use it all the time for dialysis bleeds. We see a lot of trauma in the area, so I think we're giving it, and we just have to emphasize giving it as soon as possible. Within 15 minutes, you're going to see 90% effectiveness. So we're going to have a battle. Some hospitals you bring them to, they're going to say, why the heck did you give this drug?
Well, we don't have a battle with the military. We don't have a battle with the American College of Surgeons. We don't have a battle with East. We don't have a battle with Cochrane. We don't have a battle with most of the major academic hospitals throughout the world and the United States. There are some people who take 20 to 30 years to change. Yeah, I just wonder how many people have to die for people to change. We know this is a great drug. We have clear data now, and we want to see more people using this like water, right? I mean, this is their huge statistic, but it gets your attention that you have a 10% survival benefit decreases by 10% for every 15 minutes of treatment delay. You're right, this is a pre-hospital drug. And although we acknowledge that some people have more seizures, right, that was the major trial in New England Journal of Medicine, this is a drug that works on lysine. Anything that works on lysine causes more seizures, right? I'm not surprised. And slightly more seizures, it's not a lot, right?
So you just said it. That's what I was going to say to bring it home. So the survival benefit decreased by 10% for every 15 minutes of treatment delay. So that every 15 minutes you delay, you're decreasing their survival by 10%. Just like that study you're always quoting about decreasing, you're off the chest, not doing compressions.
Right.
For how long you're decreasing survivability by.
So should we be giving TXA to anyone who's in any major trauma, even if we don't know if they have major bleeding or any penetrating trauma to the chest or abdomen, because maybe they are having bleeding by the time we figure it out, or we see that their blood pressure is dropping, or they become tachycardic, we've missed our window of that 15
Well, listen,
minutes.
I mean, these are papers we reviewed from the IDF, the Israeli Defense Forces, and they gave TXA with normal vitals, right, with better outcomes. You
as
do
soon
not
as
need
you identify major bleeding,
you do not need to wait till you have abnormal vitals, right? You identify major bleeding, and I think you have significant trauma to the box, and significant trauma is loosely defined. But if it crosses your mind, give the drug, because the question is, what's your downside?
There's a big difference between identifying major bleeding and giving it in every trauma. They're coming from opposite ends of the spectrum.
Right, so if you have like a penetrating trauma to the belly or to the chest or something, there is a potential that there's major bleeding there.
Even blunt trauma.
Or right, or like a very bad car accident, there is the potential that there is that major bleeding. We may not be able to identify that major bleeding until we get to the hospital or until we see change in the person's vital signs.
That was one of the emphasis.
The idea of protocol, though, was to first identify major bleeding and then give TSA. Your question is, should we give TXA if the possibility of internal bleeding exists, even if we have no obvious symptoms? There's no guarding, there's no rigidity in the abdomen, but the mechanism of injury shows some possibility of internal bleeding. Do we then give TXA if we have anything to lose? And that's what we need an answer from Dr.
And that is the harder question, because all of these studies, something was wrong with them. What if we give it to people, because we need a study that said, what happened to the people that had nothing wrong with them who got the TXA? Now, I have to believe that in trauma, you've hypercoagulable period where you're more likely to clot. So they're probably at more risk than a healthy population who's nothing wrong with them who got it because of the mechanism. So I have to believe it's probably even safer in those people who have absolutely nothing wrong with them. I just don't know that for sure. And I think this is all subjective. I mean, I give you a major mechanism with ecchymosis all of your abdomen, but normal vital signs, I would give it, right? But we all probably would. But what about the patient who has a major mechanism and it looks okay and is ambulatory? And I think the answer is still, I wouldn't give it to that patient. But how do I differentiate that patient who is a little something on clinical exam? That is very difficult. I don't think there's a right answer.
Single stab wound to the belly.
I think it's a single stab wound to the belly is penetrating trauma, and that's where some of the TXA literature started from. And I think those people could benefit from it, even though we know that single stab wound can just be explored locally and closed up and go home right away, right? And
That was one of the emphasis on trying to get pushing the state to change their protocol. Because, penetrating trauma to the box, your chance of bleeding is tremendous. And
right.
Let's get that started right away.
But we know one major randomized controlled trial in nosebleeds and a few other observational trials. We know literature in children. We know women's trials show postpartum hemorrhage. We need to keep pushing this. We need to keep doing exactly what the military's been doing for 17 years.
And this study only looked at the use IV, but there are several comments on the feed as well about people using it topically.
Topically,
and
yeah.
daily. I mean, I can think so many traumas where we just said, let's just put it on topically, and it works.
And we've used it topically for nosebleeds, right?
Yeah.
And you have papers on nosebleeds.
Yeah.
Right. And we've had several cases where people have like real bad nosebleeds. We put it on like a 2x2 or 4x4, and we stick it up the nose because And somebody asked me, I put on a Rhino Rock in the ER, and I don't see why not. Right now we don't have those pre-hospitally, but how about just a 4x4, stick it up the nose, for somebody who's bleeding a lot.
Dental bleeds too. People come in.
Dental
for
bleeds too.
extractions. It works great. Yeah.
A popped open fistula.
Yeah.
A bad laceration. And there was that study which gave it IV and topically. And we're just talking about some of the acute care setting stuff. The CABG literature shows decreased mortality and less transfusions. Scoliosis, orthopedic surgery, orthopedic uses it heavily for lots of different orthopedic surgeries, right? So, but we're still slow to change. I'm not sure there's any different any other topic that we're slow to change.
Yeah.
Any final comments?
Let's keep pushing it. I think just really emphasize and educate. This is a pre-hospital drug. It has to be given as soon as possible.
I think we all should put our wallets in our pockets every day and put a vial of TXA in our pocket every day, like right next to it. Always matter. But I mean, Josh, what do you want to see? I mean, I don't think we have a good answer because I think there's too much heterogeneity in mild trauma, right? It's too hard to come up with a protocol. It's sort of like you show me the patient, I'll tell you if I think TXA is indicated. And for me now, if they're in my gray zone, I'm more apt to give it, right? But I don't think that. I mean, I think it's really hard to come up with a protocol for people who aren't sick.
Okay, car accident. Patient does airbag deployment, multiple fractured ribs. Okay, possible hemothorax. Do we consider possible internal bleeding? And if so, do we give TXA? Even though we have no evidence of internal bleeding.
I think it warrants a discussion for every patient. To make it part of the protocol, I think would be difficult because every patient's not the same. But what you're describing, that's something I'd seriously consider giving it. Filling that educational gap, we have hospitals where we bring patients who have got TXA, who they go to the ICU for monitoring for thrombosis for a few days.
Right.
And
that's absurd, right? And that's absurd, right? But that is a hard question to answer. I'm not sure it's any harder to answer than a lot of things we do where they're kind of in the gray zone and we go, what's the right thing to do? Listen, the flip side is a few years ago, we didn't have this magical drug, right? So we used to do absolutely nothing. So the fact that we're getting to tough decisions now, I think is a good thing. I don't think it's a bad thing, right? I think of all the sick people, we used to just say, yep, you're bleeding and there's nothing I can do about it.
What about a miscarriage?
Yeah, but I think the problem with the miscarriage is we know TXA crosses the placenta. So what if somebody's just having bad first or second trimester bleeding, and now it's across the placenta, and you could end the life of that fetus, when maybe this is just bad vaginal bleeding, and you won't know until we do an ultrasound, and that ultrasound shows a normal heartbeat by the fetus, then you have a good likelihood that the fetus will go to deliver normally, depending on how much bleeding there is.
I'm referring to a patient who is already at their OB, who told that they're actually having a miscarriage, and perhaps they're waiting for a DNC in the next couple of days, or they're just waiting to do something, but the doctor already said that it's not viable, and now the patient's bleeding, they're hypotensive, or maybe they're still compensating, so they're a bit, they're tachycardic. While we're treating them, we're going to give them some fluids to try and maintain their pressure. Do we give them TXA? I know I had a case like that, and I spoke to the doc on the
Right.
box.
I mean, odds are, if you just play the odds, that person's hypertensive probably because they're vasovagal, right? Because most people don't get hypertensive.
Hypotensive.
Right. Most people,
Should bleed.
most don't get hypotensive from vaginal bleeding, from DNCs or from just inevitable ABs, right? Because they just don't. We see 20 women a day who have this, and most have normal blood pressures, right? So I'd be thinking maybe they're just vasovagal because they're seeing all the blood, and that's why, and this is something transient. 2, if you're giving IV fluids, hopefully it's because the systolic is less than 90, otherwise you're just diluting out clotting factors, and it may not be a good thing. But 3, I think, yeah, if they're truly hypertensive because there is a large amount of blood loss, and you see that as opposed to patients objectively telling you, I think TXA is totally okay. But I would give that patient like a chance to like just for the vasovagal to correct. Okay, let's do the next article. Who's doing the next one, Josh?
Sure. Talk about septic shock resuscitation in the first hour.
So sepsis has become a big conversation in the pre-hospital arena for multiple reasons, but it's important to stay up on the sepsis literature, which, if you don't know, changed in 2016. We totally changed our definition of it. We totally are using a different criteria now. We're using QSOFA and all these things now to determine sepsis. We're moving away from SIRS and all those topics, and we're doing now silly things. I personally think the sepsis literature is the most confusing literature we have now in all of medicine. I think it's much more confusing than TXA, believe it or not, because we do silly things like 30 per kilo. Go ahead, Josh.
Yeah, I mean, I think this was a good review article, kind of really discussing the different things that we do and the different possibilities of what we have. And I think it really highlights the point that we don't really know what we're doing in sepsis, unfortunately. I think there was a lot of progress made from the Rivers trial, and I think in identifying sepsis and as we all know, there were issues with that study, and we've kind of took this swing, I think, from maybe not treating sepsis very well to this other end of the spectrum of doing all these things that may or may not work, and then and this article kind of broke down the different things that we have and what we do. And a lot of what we're doing is based on very little evidence. I think it's good to understand these concepts and to kind of get an overview of everything that we are doing pre-hospital and in the emergency room. And I do think this is definitely a worthwhile read. It takes a little while to kind of get through and understand everything, at least it did for me. But I think
you read like 4 times before it's really
there's a lot of complicated stuff in there.
You just give us a couple of highlights.
So a couple of highlights. So basically, this kind of looks. So when we look at sepsis, we can look at micro and macro circulation. If we're looking at micro circulation, we're talking about the capillaries, the venules, the little blood vessels, and we get down to a level of the endothelial barrier, which is disrupted, and that can be caused by loss of vascular tone, and we get leaky capillaries, which possibly would then say maybe we need more fluids to replace all this we're losing. We also look at the macro circular, which are the larger vessels, and I think they gave, if I remember correctly, there was a diameter, but I don't remember it off the top of my head. And then the question is, should we care about the microcirculation in sepsis? We look at lactate clearance. We've seen that lactate clearance is associated with survival, but then it kind of talks about, well, maybe the lactate isn't from the hypoperfusion of the cells. Maybe it's from all the catecholamines that we have going on. So it's not really tissue hypoxia. We don't really have very good studies kind of to determine what this lactate is that we're necessarily measuring. And so maybe so if it is from the catecholamines and we improve the microvascular circulation, it's not really changing the lactate that we have. So we looked at fluids here as well. So when we looked at fluids, there's a lack of clarity in terms of the types of fluids and to administer. There's arguments to give lactate ringers, there are arguments to give normal saline, well balanced fluid, but whichever fluid, and it said it kind of here, and it says whichever fluid and volume is chosen with limited and conflicting evidence in the setting of septic shock, it is important that the therapeutic agent is considered a drug and administered with such caution. I think that was something that's really kind of pivotal to understand in this, that when we are giving these fluids, we don't really know what we're giving, but it can cause, giving too much fluids can definitely cause issues as well. And it's not just saying, okay, this person I think needs 30 milliliters per kilogram, and we just bolus them in, and now we're giving people 2, 3, 4 liters of fluid, and we could definitely be fluid overloading them because maybe it's not really what we need to be doing for them, and we do need to think about these things.
Because we have no single study which says 30 per kilo is the right amount of fluids to give. And we have several studies which show 30 per kilo harms people, right? And we're not talking about the people who are hypotensive, who are sick and dying. They probably need more fluids. Although I don't know that 30 per kilo is the right dose. It sounds somewhat reasonable to me by consensus panel because of the Surviving Sepsis campaign. But I do know that if you're not hypotensive, you've increased risk of renal failure, you've increased risk of ARDS, you've increased risk of pancreatitis. That's what several papers now in the literature have shown. This guy, Josh Farkas, who's a critical care guy, wrote this great review article, how we're harming people by giving 30 per kilo of fluids. Again, if you're hypotensive, like many of our septic patients are, then that's reasonable. I mean, Josh, you trained at Jacobi. You saw a lot of septic patients there. Were you giving 30 per kilo?
Yeah, I mean, I think we were probably giving 20 to 30 per kilo, I would say. And now with the advent of ultrasound also, we can really kind of see what's going on with their physiology, and we can look at the IVCs and see, are we filling them up? Are they full already? Where, if we just use these numbers, I feel like it doesn't always do justice. We have the ability to be smarter than just taking a number and saying, let's do this. We can look at what we're doing. We can assess our patient. We have other means to kind of see exactly what we're doing and the effects that we're having on our patients. So when we use those things, I think all in conjunction, and we can kind of tailor our care a little bit better to each individual patient depending on what they're coming in for.
Right, and we can say, and right from the article, using lactic levels is a weak recommendation based upon low quality evidence. But people live or die by that lactic acid level,
Absolutely.
right? Like nothing else matters. I'm like, well, maybe it was drawn on the wrong patient. Doesn't matter. We got to act on it, right? I mean, it's just silliness. I mean, we forgot to look at the freaking patient, right? And we've got to look at the IVC, and sure, the IVC is not a perfect measurement of volume status. It's certainly better than not looking at the IVC, right?
Yeah, I was just going to say lactate by itself doesn't tell you anything. I think really consistently the studies that show any benefit of using lactate is lactate clearance, because that has an effect on that prognosis.
Haven't you guys ever drawn lactate on somebody by accident, and you come with a high lactic on like a kid with a strep throat, or you come up with someone with a simple stomach virus that comes back like 2.5, and you go, wow, I'm glad they didn't have a fever. They would have gotten 30 per kilo. It doesn't really make a lot of sense.
Yeah, and then the classic trial, which it discussed as well, and it talked about using a more restrictive approach to fluid therapy in septic shock, and they found that by using this lower cumulative resuscitated fluid in the ICU, that there wasn't any increased risk of adverse outcomes. So, maybe we don't need to be giving as much, and maybe there is a role for some sort of restricted fluid. I think,
because the 30 per kilo is in the first 3 hours. Most people don't do that. They give it in the first, 30 seconds, right? Because you have to do it right away. And again, if somebody's hypotensive, has no blood pressure, and it's all from volume loss, all right, I'm on board with giving more fluids, right? I get that. But a lot of our people, we're kind of going to flu season. What if a lot of people walk in with like 103, and somebody gets a rapid lactate on them and it's high?
They're getting bolus and they're getting
Right. All the people we see with EFs of like 10% are now going to be in heart failure, right?
The thing that really drove this article home for me was, there's such a focus on macrovascular resuscitation. It's not that simple. As our program director at NorthPath always says, it's not that simple. But anyway, they emphasize that if you think about it from a physics standpoint, fluid, like flow, what is that? Poussin's law.
We'll get to that.
Right? Yeah. So I mean, if you're focusing on clamping down, you're actually decreasing the diameter of the vessels, reducing flow to distal tissues, and that makes total sense to me. Why do we care about that? It's a very dynamic process, I think, of messing with like the glycocalyx within all of our vessels and everything like that, and you're just messing that up by throwing all this fluid at it.
But we talked about the glycocalyx in our clinical pearl of 30 per kilo being made up, right? We talked about how maybe that's really the major thing that we need to look at. And anything else with the article, Josh?
I mean, I talked about the vasopressors, which I think is also interesting.
So summarize the vasopressors.
So quickly on the vasopressors, so it's something that we, I think, get pushed to go to quickly. You know, we give the fluid, someone's not responding, or their MAP is low, we add on vasopressors. But like Mike was just saying, and Poiseuille's law, we give vasopressors, we're constricting the vessels. So I don't know if you want to put up the law and define all the codes on it.
You tune into EMS Journal Club and you get physics laws.
This is really why I like the article, because of the Poiseuille's law.
No, I mean, listen, if a patient's in septic shock, they're going to say quickly, before the fluids, tell me what the law is.
Exactly. But you have the pressure, you have the radius, and the radius is to the 4th power. So by decreasing that, you know, we're definitely decreasing the flow. So by constricting the vessels, we may be constricting the flow to end organs, and we're reducing organ perfusion. So maybe giving vasopressors isn't, and maybe we should even be giving vasodilators to these people then.
What's wrong with little hypotension, right? We show this with, you know, your hemoglobin dropping to 7 grams if you're bleeding, right? We show this with, you know, permissive hypotension. You know, what's wrong with keeping the blood pressure low, right? Nothing. And if you're at least 90, you're probably not hyperperfusing many organs in the average person, right? It's just a generalization.
Right. And the law is right there in the video so everybody can see it and follow along.
All right, good.
And then they talked about the renin-angiotensin system and possibly giving exogenous angiotensin too, which I actually think is it sounds pretty cool. I need to look more into it. But it sounds, in theory, interesting, that instead of giving people potentially vasopressors, you just give them this exogenous angiotensin 2. And there was a trial that showed that 75% of patients with catecholamine-resistant vasodilator state in septic shock, that their blood pressures actually improved. So this is potentially another way that we could kind of get their blood pressures better and improve their perfusion. So I think overall it was a good article, and I think it's definitely important to recognize sepsis, to start to treat it early, and then to think about what we're doing and not just say, you know, this is what we need to do because of some numbers that are kind of made up, but to really think about it, each person, and to constantly reassess them and reevaluate the care that we're giving, the medications we're giving, the fluids that we're giving, and to titrate them. It's not just give this one medication and forget about the patient and come back. And as one of the attendings where I trained always said, you know, it's stay by the bedside and see what's going on with these people every 15 minutes. It's not just give them their 30 milliliters per kilogram, give them their norepi, and then go check on them in 2 hours, because a lot will happen in between.
All right, great. So we'll do one more, and this was just a cute little review article I saw, which we usually don't include review articles in throwaway journals, but this was actually pretty good, and I think this is relative to what we're seeing all the time. And it's being done with Alex, who's officially known as the 4th EMS fellow, because Alex is Air Force, so he's a little bit off cycle, so you may not have, the 1,000 of you or so may not have met him. So we're going to talk about the novel new blood thinners.
This is something that has been reviewed in my residency multiple times, but with more patients kind of coming in, you're seeing more patients on Pradaxa, or on Pradaxa, Eliquis, Xarelto, whatever it may be. These drug companies are handing out free coupons, this, that, or the other. Patients are on this all the time.
And we just have to say we do not endorse any specific NOAC or DOAC.
And we should be saying that we know we only should be using generic names. Just with these drugs, they're too freaking difficult.
And in the article, it specifically discusses Pradaxa, Xarelto, Eliquis, and Cyvasa.
Right, which is in medicine is for these drugs, just the names we use every single day.
Exactly. So these are the terms coming out of the article directly. That's why I'm discussing these particular NOACs. So the coagulation cascades there for review. The majority of them are working on factor 10A. Dabigatran, Pradaxa is working on is the direct thrombin. So,
but let me just say that all the 10As have XA in the generic name.
Yes.
right? So that is a cheat way
Yes.
versus the direct thrombin inhibitors, which don't, right?
Exactly.
Right.
So going through the articles, talks about how you're seeing these drugs used more often, and the concern is what happens to these patients in terms of, do you need to reverse it for bleeding? For warfarin, there was the FFP that we used in the past, and then there's talking about using different types of reversal agents. And the first step was defining what constitutes major bleeding, because that's when we were going to be using the actual reversal agents. So this article discusses formal definition pretty much as a symptomatic bleeding in a critical area of origin, which is intracranial, intraspinal, intraocular, pericardial, retroperitoneal, or intramuscular with compartment syndrome, and or bleeding causing a fall in the hemoglobin of 2 or more, leading to a transfusion of 2 or more units of red blood cells. And then also patients that are requiring emergent surgical intervention is another group where rapid reversal is indicated. So it kind of mentions that some of these medications have short half-lives, 12 to 24 hours, and then discusses laboratory measures somewhat that really shouldn't be a guide in terms of the reversal on these. But essentially what it's saying is that the decision's made to reverse it, you need to kind of figure out which agent they're taking. And the figure presented in the article kind of separates the dabigatran on one side, since that's a direct thrombin inhibitor, versus rivaroxaban, apixaban, and edoxaban, which are the 10A inhibitors. Again, those all have XA in the name. So in 2015, dabigatran actually came out. FDA approved them to have what's called Praxbind, which is, I'm not even going to attempt to say the name, it's a monoclonal antibody.
I dare you, Sisomap.
Yes, that one. So that was approved. It's a monoclonal antibody that irreversibly inhibits dabigatran, and those are given in 2 IV boluses. So it's not readily available. Not all facilities have that. But if you know for a fact that your patient is on that, one of the things that the article mentioned is figuring out when they took the last dose of that medication, because essentially if you have activated charcoal comes into play in terms of as a potential reversal option. So specific with the dabigatran, it talks about activated charcoal can be given. It says this is an option if the last dose was taken less than 2 hours earlier. Another option, if you don't have the Praxbind available, hemodialysis is another option, and it also discusses about using the PCCs, which are prothrombin complex concentrates. There's 3-factor and 4-factor concentrates. I think it's just dependent on facility. Every facility I've been at has the 4-factor, which is the brand name's Kcentra. That has factors 2, 7, 9, and 10. Also has a little bit of protein C and S. And if I remember correctly, looking at it, also has a little bit of heparin in it as well.
And I forget what company Kcentra is, but they're at all the major conferences now. They're like everywhere.
Yeah.
Right? So it's getting more and more common to be used because, FFP, we did a terrible job reversing Coumadin with FFP. We always it should be somewhere between 10 to 15 mg per kg. We always gave too little, and it didn't work as well as Kcentra does in general.
And then there was also with I'll talk more kind of about the Kcentra and that stuff with the 10A inhibitors, but this is an option if you don't have Praxbind available for the dabigatran. PCC is an option, hemodialysis, activated charcoal if they're in the appropriate time. TXA is also in there, and
another great use for TXA.
So since we have a great plug, let's use it.
Yeah.
So these are all options. Again, the Praxbind is relatively new. It's very expensive, but it is available. It talks about the dosing, how it's 2.5 grams IV times 2. Essentially, the last time I saw it used was call the pharmacy, say, hey, I need this, and they get it for you. It's there. So that'll kind of, with regards to the dabigatran, that's kind of how you would consider reversing that. Going to the 10A inhibitors, which rivaroxaban, apixaban, and edoxaban. I think the most common ones that we see are the rivaroxaban and apixaban are the most common. These are looking pretty much one of the primary ways to reverse these are the PCCs, Kcentra being the most popular, most commonly available. This is pretty easy dosing. It's 50 units per kg. You give that IV. It's a very low volume, and it's pretty quick to reconstitute and give this medication. The problem before using, especially with warfarin, reversing it using FFP was volume overload. You had the antibody reactions. Took time to thaw it, so there were multiple problems with the FFP. So going into or having this availability of the PCCs, and it's pretty much one dose, 50 units per kg. So it's great for all of these 10A inhibitors. Other options are the 3-factor PCCs. There's also recombinant factor 7, which is Novo 7 is the most commonly available.
Which is what the military used to give before they started giving TXA to everybody. The problem with the reason they stopped is because 17 years ago when they stopped doing it, all these young healthy recruits were having big DVTs and PEs.
Clots.
So like real big ones, so they stopped doing it.
Yeah,
and Nova 7 was very expensive.
Yeah, and that's it's very expensive. And the other thing is that it's also, like Dr. Merlin said, it's also very, it's almost it's a prothrombotic agent. So you have a lot of patients develop thrombus formation later on. Again, TXA comes into play again as an option for reversal of these, and then activated charcoal is an option. One of the things that I've read a lot, I think it was through West Virginia University, if I remember correctly, but andexanet alpha was another agent that is supposed to pretty much mimic the structure of the 10A inhibitors, and was going to be is in studies to become available for a potential reversal agent. So it's one of those where it's based on the studies and what they're doing so far. It's supposed to be within 5 minutes you see an effect and has much better reversal than the others. And this also can start working against the low molecular weight heparins and other agents as well. So that's something that is in the works. It's still undergoing clinical trials. So that might be something in the future, but as it stands right now, pretty much if it's dabigatran, you can go Praxpine if you have it. If not, TXA, PCC, and then same thing with the 10A inhibitors, you can go straight with the PCCs and TXA.
That's great. Any questions or thoughts? I mean, baby boomers are getting older, more people on these drugs, more people hitting their heads, more intracranial bleeds, more bleeding in general. We're going to start having to all be experts on how to reverse this. And
that's one of the big things now with all these stroke committees,
yeah,
that so many people are on so many different drugs. It's like, it becomes incumbent on us in the field to make sure that we find out what drug they're on.
Right. The problem is you can't give these meds without having a CAT scan. The problem is, I mean, I don't know what Praxipine costs, but I mean, it's a monoclonal antibody, right? It's got to be
super expensive.
Yeah, it's got to be like really expensive. It's not like TXA. TXA we actually get for very cheap now.
Almost cheaper to do dialysis. Just
right.
If you can dialyze peroxide,
right.
dialyze.
And the problem is it's difficult to do fast dialysis in the middle of the night, right? Because somebody has to come in and from home to do dialysis in the middle of the night.
Also, the article, he keeps mentioning activated charcoal. Activated charcoal will be relevant if the drug is sitting in their stomach. If somebody's been sitting on Xarelto for the last 8 months,
yeah,
I'm not sure that activated charcoals are issues.
Yeah, they say in the article, if ingested in excess within 2 hours, you can.
Yeah, and I even like the 2 hours
somebody
because
who's trying to commit suicide or something.
Right, but if you're talking about a patient that's on a given dose of
so even I think if they take their dose, let's say at 8 in the morning, and they show up at 9 o'clock with a bleed, you can still give them activated charcoal, and whatever is not absorbed might still.
What about the Xarelto that was absorbed yesterday?
So it has a half-life of like 12 hours, so it's a pretty quick half-life. It's already metabolized out.
Right, that is one benefit of these drugs. They have very quick half-life, so they're out of your system pretty quickly.
It also mentions activated charcoal IV that I've never heard of.
What IV?
Me neither, I don't think.
It's got to be a mistake.
Yeah. I mean, I don't even like the 2 hours of the activated charcoal because the 3 big papers in activated charcoal all said 1 hour. Give it if the drug is still in your small large bowel within 1 hour. So I don't even like 2 hours.
Again, also I think giving someone who's having major bleeding or brain bleed activated charcoal and it causes them to vomit and all this
yeah,
stuff.
it's not good. Right. It's the major reason why we don't carry activated charcoal pre-hospital.
Yeah.
All right. Anything else with that?
Other thing is it talked about procedural stuff in terms of talked about kind of do you need to reverse it emergently for procedural stuff. I mean, I would probably say no. Talk about lumbar puncture. I mean, if you really need to do a lumbar puncture, hold the dose, treat them, and do the diagnostic LP later. And that's kind of what the article agrees with as well, because 12, 24 hours they're out of your system. So.
Yeah, we used to run an FFP. We used to do FFP before, and then as it was running in, do like a paracentesis or do an LP if it was really needed. But most of the time, it's not really needed. So yeah, right. So congratulations for a nice, simple, our first ever throwaway journal. Although it's probably not nice to say, but the first ever like nice, simple article that we reviewed that we thought was well done. Congratulations to Dr. Ilbert from University of Illinois, and I think one of our incoming fellows, one of our superstar incoming fellows is from University of Illinois. So thanks. So we will be back next week. We will be in North Jersey next week, and we'll post this very shortly on both our website and once we edit on Facebook live streaming. And any other announcements? No? Okay. Thanks everybody for tuning in.